invite Dr. Aditya, the department head of Shankara Hospital, Bangalore. He is a well-known figure in the field of optometry. He was instrumental in establishing the College of Optometry in Chennai, Bangalore and Ludhiana. He is the mentor of optometrists in the Shankara Eye Group. He is the alumni of the elite group of optometry. We welcome you, sir.
Good morning, everyone. Wonderful to be in Kerala, love the place. And like what Dr. Padmaja just mentioned, objective refraction, that is with retinoscope, not with automated refractor. I think that's the best thing you can do, because that is where you get to know what is exactly happening within the eye, and automated refraction does not even tell you what is happening within the eye. 35 odd years of my life, I've used autorefractor only once in my life when I was doing my exam in US. Apart from that, I've always worked with a retinoscope, and it's a fantastic tool. So when Dr. Padmaja was talking, I remembered a long back there was a debate in Shankara Netralaya on autorefractor versus retinoscope. I made only one statement. Autorefractor is a wonderful tool in the hands of an intelligent optometrist or ophthalmologist, and a disaster in the hands of an idiot. And that's exactly what I personally believe. Autorefractor is not a bad tool at all, but then you should know how to use it, and most importantly, how to refine your prescription subjectively. Because if you do not refine it properly, that is exactly what your patient is going to wear over a period of time. So you should have a perfectly refined prescription for a patient, for a prescription. So basically, when we are talking of subjective refraction, you're looking at two things: monocular subjective and binocular subjective. So all of you have been doing a lot of monocular subjective. I'll lay more emphasis on binocular balancing and binocular subjective refraction. But all the same, let me go through a little bit of monocular subjective, where we are looking at the monocular endpoints, spherical endpoint, then you look at the cylindrical power using a JCC, refine it, and finding the spherical and the cylindrical endpoint. That is where your monocular subjective ends. Binocular subjective is most important because it is something like balancing both the eyes. Now, I want to know how many of you do binocular balancing? Nobody? When you do your subjective refraction, do you balance both the eyes? You don't. Okay. So I think that will be something important for you, because it is something like if you're wearing a shoe, one has a 4-inch heel and the other has no heel. Will you be able to walk properly? So that's exactly where binocular balancing is, where we are trying to balance the accommodation between the two eyes. Because monocularly you might have overstimulated one eye or relaxed the other eye, or anything could be happening. So it makes a lot of sense when we binocularly balance both the eyes, the accommodation in both the eyes. So we are looking at balancing both the eyes, and then refining the spherical power. There are certain miscellaneous tests which we will not go through. 15 minutes is not sufficient to go through all those tests. So these are some of the miscellaneous tests that we do. But let me quickly go through monocular subjective and then come to binocular balancing. Now, how many of you use Jackson's cross cylinder? Only one? Alright. It's a very important tool, because that is what gives you a proper refinement of your axis and the power. Alright, so initially what we are doing is maximum plus to minimum minus for maximum visual acuity. So you occlude the fellow eye and then you start working on your objective value. You work only on the spherical first, wherein you keep on adding the plus power or the minus power till the time your patient is just able to see the best corrected line. So let us say he has 660, you keep adding plus power or minus power depending upon what your objective value is in sphere alone, and then at one particular time it will not improve any further. that is the best monocular subjective refraction that you can do. Now, what we want to do is maximum plus or minimum minus for the best visual acuity. Why do we do that? Maximum plus or minimum minus, because if I start giving more minus, I'm going to stimulate accommodation, which today there's a lot of hoo-ha about myopia and myopia control and myopia progression. So that is exactly what is going to happen, because if you stimulate more accommodation, that much more myopia is going to be created, and your brain gets used to that, and after a few months again the patient comes back to you, you again prescribe that higher myopia, and myopia keeps on progressing. So that is the reason why we like to give maximum plus, minimum minus for the best visual acuity. How many of you do diochrome? Again, 1, 2, 3, okay. A lot many. Fine. So what do we do in diochrome? You have some letters in black color over red background or the green background. Now it is working on the principle of chromatic aberration. Okay. So if the patient, what is the question that you ask? Do you ask, are you seeing it clearer, or do you ask, are you seeing it better? I think we should ask which is better, because clearer starts stimulating accommodation. Okay. So against one background, either red or green, the patient sees something better. So if the red is better, then you keep on increasing minus power or reducing plus power. If the green is better, you increase plus power and reduce minus power. Okay. And where both are almost equal or one towards the green is better, just stop there, and that is your subjective spherical endpoint. Never ever do duochrome for cylinders. Duochrome is meant only for sphere and not for cylinder. Now this is a great tool, Jackson's cross cylinder, that we use, and you see the black lines and the red lines. Red line in this particular thing is for the minus power, and the black is for the plus power. So the first thing that we do with the Jackson's cross cylinder is refine the axis of cylinder, because power will come later, because if the axis is wrong, you're going to get a wrong power. So you have to refine the axis of cylinder. So whatever objective cylinder you got, have your axis placed, have your cylinder placed in the trial frame or the phoropter. Keep the handle of the Jackson's cross cylinder parallel to the axis, and flip it over. You show your patient two positions, one and then the second one. Whichever the patient feels is better. If you have a minor cylinder, move it towards the red. If you have a plus cylinder, move it towards the black. So move about 5 degrees towards red or black till the time your patient says both are equally clear. Then you go on to refining the power of the cylinder, where you put the lines of these, either the black or the red lines, parallel to the axis. Earlier you had the handle which was parallel to the axis, that was for the axis. Now for power refinement, have the marks which are parallel to the axis. And once they're parallel to the axis, let's say you have a minus cylinder in place. If the patient says he is better with the red lines which are parallel, increase the minus cylinder. If he says the black lines are better, then decrease the minus. Okay. Is that clear to everyone till now? Great. So once you have refined your sphere, you have refined your cylinder, your axis is perfect, your power is perfect, and your patient is possibly seeing 6/6, you feel that you have achieved the ultimate? No. That is where the role as optometrist comes in, and you have to binocularly refine the prescription. Like I told you, the accommodation, you're doing your monocular refraction. At that time, what can possibly happen is you might have overstimulated one eye, accommodation in one eye. You might have understimulated accommodation in one eye. So you have to balance both. Now, how do you go about balancing? The first thing you have to do is negative and positive relative accommodation. Now, what is negative and positive? Yeah, one more thing. These have to be done for phakic patients. Please do not try for aphakic or pseudophakic patients. It does not work for them. Secondly, the patient should have almost equal acuities in both the eyes, invariably 20/20 or 6/6 in both the eyes. Otherwise, if it is 6/60 in one eye and 6/6 in the other eye, don't bother about this. All these things don't work. Okay? So let's say your patient has 6/6 acuity in both the eyes. You do NRA-PRA, which is negative and positive relative accommodation. What we are working towards that is, we want to find out how much of accommodation with your prescription your patient is able to relax accommodation and how much of accommodation is stimulated. With the negative relative accommodation, we are relaxing, and with the positive relative accommodation, we are stimulating. Now, what do we do in this? It's a binocular test. The reason why it is binocular is that we are checking accommodation relative to a constant vergence effort. So we are keeping the target, your N8 size target, at 40 centimeters. So that is providing some amount of convergence to the patient. Keeping that convergence constant, you are changing your accommodation. So whatever your prescription for the patient has, binocularly add plus 0.25, and the instruction to the patient is, let me know when the target becomes blurred. Sustained blur. Sustained blur is when the patient is not able to clear with the maximum possible effort. So let me just make it clear to you. You have your subjective monocular, subjective refractions. Keep both eyes open. Give a target, N8 size target at 40 centimeters. Keep putting binocularly plus lenses, plus 0.25 in 0.25 steps. Keep on increasing and ask your patient when the what he's seeing is totally blurred and with the maximum effort he cannot make it clear. Now, can you tell me how much should be NRA? Any guesses? What should be normal NRA? Like I said, NRA is relaxing accommodation. We are working at 40 centimeters. So what should be normal NRA? No guesses? Ideally it should be 2.5 diopters plus 2.5 diopters, because 40 centimeters stimulates 2.5 diopters of accommodation, right? And when you have done a distance refraction, what is the end point of your distance refraction? Accommodation was totally relaxed. When your accommodation is fully relaxed for distance and you're checking the NRA at 40 centimeters, you should be stimulating 2.5 diopters of accommodation. So if I'm stimulating 2.5 diopters, how much can I relax? I should be relaxing only 2.5 diopters. I can't relax more than that. I can definitely relax less than 2.5 diopters. But once it is totally blurred, that means my accommodation is fully relaxed. Am I right? Okay. So if, let us say, you do your NRA and your value is plus 4, what does it mean to you? You have overstimulated accommodation. The patient had 4 diopters of accommodation. So what have you done? Either you have prescribed less plus or more minus. So in our hospital, we made it a kind of rule that every patient has to undergo NRA-PRA. People used to make fun of me. My students used to call me, they had nicknamed me NRA-PRA. But then today we have made it a kind of protocol where in our hospital, every patient undergoes NRA-PRA, and we are able to find out how many patients we are overcorrecting. We usually don't undercorrect, but then overcorrection of myopia or undercorrection of hyperopia is clearly seen when we do this NRA. So once you have completed your NRA, you come back, 0.25, 0.5 down, come back to plano, and then increase minus. Minus is going to tell you that is PRA, that is going to tell you how much the patient can possibly stimulate. Now if you add both NRA and PRA, just the values, not the signs. Let us say NRA was 2.5 diopters and PRA is 6 diopters. What does it mean to you? The range of accommodation was 2.5 diopters plus 6 diopters, which is 8.5 diopters. So you're able to find out the patient's accommodation range. Is that clear to you, all of you? So you're supposed to do this NRA and PRA, and that gives you a proper understanding of accommodative status of your patient. Once you have achieved that, then take off your PRA values, go to NRA, take a patient to the distance vision drum. You remove your 40 centimeter near vision target, take the patient to distance vision drum. And once he's on the distance vision drum, he'll see nothing, because you have plus 2.5 diopters or so in front of his eyes. Reduce plus 0.25 binocularly till the time your patient is able to see 636. Okay, so you keep on reducing 0.25, and at one particular time, your patient will be able to see 636. Now you put base up prism in one eye and base down prism, small amount of it, probably about 2 to 3 diopters or 4 diopters of prisms, basically to dissociate the two eyes. I want to check the accommodation in both the eyes. Now he is seeing 636, you have dissociated the two eyes, he'll see one set of letters here and one set of letters here. Now your question to the patient is, which of the two is better? Let's say he says the one at the top is better, and you have those prisms in the right eye. What are you going to do? You're going to add plus 0.25 to that to make it blur. When the patient is seeing better, what does it mean? That he was stimulating more accommodation in that particular eye. I want to relax that accommodation. So please keep adding plus 0.25 diopters in the better eye till the time your patient says both are equally clear. Once your patient says both the eyes are equally clear, remove the prisms, make them fuse, and then reduce plus binocularly till the time your patient is able to see 6/6 perfectly with the least minus or the maximum plus. That will binocularly balance both the eyes. I'll tell you, very recently we had a case where we had prescribed, I think, minus 3.5 or something in one eye and minus 3.25 in the other eye. And the patient had diplopia, patient had a whole lot of problems. He had had some stroke, but then all the same he had diplopia with that. So we prescribed some prisms also, but the patient was not happy with those prisms. Then he came back again saying that he was not satisfied with that particular prescription. We did a binocular balance, and guess what we found? He had a 2.25, minus 2.25 in one eye and minus 2.5 in the other. And with that minus 3.5 and 3.25, we had prescribed a presbyopic addition also. We had prescribed plus 1 diopters of presbyopic addition. Now with the minus 2.25 and 2.5, he didn't require any presbyopic addition. He was able to see perfect 6/6 in 6, and he had no diplopia. So it is very, very important that we binocularly balance the prescription, and once it is binocularly balanced, prescribe it. Your patient will say that yes, I am not happy with this initially, because you are prescribing more plus and less minus. But explain to the patient that it is necessary and what you have actually done, and all the patients will take it. Once you have done that, look at your duochrome. You could do a binocular duochrome by putting prisms in the eyes. You could balance both the eyes perfectly well and prescribe those glasses with full confidence, and no patient will be dissatisfied. And I think we will be able to control myopia considerably with proper prescriptions. We don't require those funny lenses and funny methods that we are talking of today. One more case I would like to tell you. I think I'm running out of time, but just one case where this patient had come. He was in Bangalore. We have every second person is IT professional. So he had come, and then he had a -4 or something. And we did a refraction, and he was -5 or something at that time. Somehow that patient landed up with us in the binocular vision clinic, and when we did a NRA, PRA and all the tests, we found that it was high. We did a cycloplegic refraction, NRA, PRA and everything came down, but still it was high. We did atropinization. We don't usually do it, but then because of this particular case, we did atropinize him. And after that, can you believe what the power was? We had been prescribing him -4 or so. He was a hypero. Ultimately, he is happy today with +3 diopters of hyperopia. And we had made a myope out of him. So your subjective refraction is very, very important. Please let me know in case you have any questions. Thank you for your attention. A lot of people who we are prescribing today, they actually do not require that much of myopic prescription.
Especially in today's pediatric age group, when you are over-minusing the children, they tend to have progressive myopias more often. So we have to have a minimum minus, always not undercorrect. Correct? Exactly. Appropriately. Undercorrection is not used nowadays for myopia. It has to be corrected appropriately. So either you have to remember that maximum plus and minimum minus. That is the which is minimum minus means the minus which is acceptable to the children appropriately. So
something like with some power you have patient C6. If you give more minus, he'll say it is even better. So don't do that, because minification neurologically makes the things better for a human being. Thank you.
thanks a lot for the wonderful talk, sir.